Bismillahirrahmanirrahim. Assalamu alaikum. So today we are going to study about the surgical incisions of the anterior abdominal wall. Now first let's start with the introduction. So a surgical incision is actually a cut that is made through the abdominal wall to reach organs inside the abdomen. That means to reach the viscera of the abdomen. And usually the surgeon cannot make the incision randomly. And there are actually three important anatomical factors that determine that how the surgeon is going to approach and is going to incise the abdominal wall. And that three important factors are actually the length, the second is the direction, and the third is the position of the incision. Okay, the length, the direction, and the position of the incision are actually determining how the surgeon is actually going to incise the abdomen. Now let's study the factors that are governing the incisions. So our book, that is Snell's, our recommended book of UHS, is actually mentioning three factors, and that are first is the position and the direction of the nerves. Now why? What is the reason? So the abdominal wall receives its nerve supply from the lower thoracic nerves. We have already studied it previously, that they are receiving its nerve supply from the lower thoracic nerves. So if these nerves are cut, what is going to happen? Muscles supplied by them become paralyzed. So therefore, incisions should avoid cutting major segmental nerves whenever possible, because that is going to lead towards the paralysis of that muscle if a nerve is cut. And so let's start with the position. That was about the position and the direction of the nerves. That why is it important and why is it governing the abdominal incisions. Now the second factor is the direction of the muscle fibers. Now we all know that each abdominal muscle has fibers running in different directions. For example, the external oblique, it has the fibers that are running infromedially, that means they are running downward and medially. And about the fibers of internal oblique, we already studied, they are running supramedially. Supramedially, that means they are running upward and medially. And then about the fibers of the transversus abdominis, these fibers are actually the transverse. And about the rectus abdominis, so rectus abdominis is a vertical tract muscle and its fibers are also verticals. That means each abdominal muscle fiber has different directions. So if the incision is made parallel to the muscle fibers, that means there will be less damage to the muscles, and that means indirectly it means that the healing will be better, the pain will be less, and the function is preserved. Okay, now the third factor that is governing the incisions is about the arrangement of the aponeurosis. The aponeurosis of these three muscles are actually these three muscles. What are these three muscles? I am talking about external oblique, internal oblique, and transversus abdominis specifically here, and they are going to form the rectus sheath. Okay, now the anterior abdominal wall contains strong aponeurosis. Okay, so actually these provide strength. So if the surgeon cuts them carefully and repairs them correctly, the abdominal wall regains its strength and it can restore its original strength even after the incision. Okay, so that's the importance of abdominal incisions, and this lecture is very important for the students who believe that or who want to pursue their career in the surgery, especially because the surgery this is the major concept that we need. Okay, then let's study about the skin cleavage lines, that are the Langer lines. This concept is very important, or you can say the core concept in this topic are the Langer's lines. So our book states that ideally incision should follow the skin cleavage lines, and the skin cleavage lines are also called the Langer's lines. Now why? What is the reason behind this? Because collagen fibers of the dermis naturally run in these directions. The directions that are called the skin cleavage lines, actually the collagen fibers of our skin are running in these directions naturally. So what is the benefit? If the incision is performed along these lines, the benefit will be there will be smaller scar, there is going to be better cosmetic appearance, and there is also faster healing probability, and there will be less wound tension. Okay, so but what happens that sometimes the surgeon must compromise, because that time there is a situation demand. Now what is that actually means? Because that means the patient safety comes before cosmetic appearance. So If a larger incision is required to save the patient's life, the surgeon ignores the cosmetic considerations only in that specific case, and that he can perform along that according to the situation and what is the demand at that time. Okay. Now, what happens if the segmental nerves are cut? Okay. What is the effect of cutting segmental nerves? So this is an extremely important viva question. Okay. So if one of the major segmental nerves is divided, that means muscle supplied by that nerve become paralyzed ultimately. And what happens that the part of the rectus abdominis, it loses its function, and the abdominal wall becomes weak as a result. So what that leads to, it leads to the bulging outward or visceroptosis of the abdominal wall, and that bulging is called the visceroptosis. Now our book specifically mentions this term, and it means the visceroptosis, it means that the weak abdominal wall allows abdominal contents to protrude or sag forward because muscular support is lost here, and that is actually very severe, and the very even in extreme cases it may require a surgical support belt. Okay. Now, what are the principles of the muscle splitting? There should be some principles that one or a surgeon has to follow while performing this. So, according to our book, if the incision follows the muscle fibers, when surgery ends, the muscle fibers naturally fall back into the place. And what will be the result of this? There will be normal function retention, there will be less damage, there will be better healing, and this is why muscle splitting incisions are preferred over muscle cutting incisions. That's the difference between the muscle splitting incision and the muscle cutting incision, because here we are actually splitting the muscle, but in other case we are actually splitting the muscle. Okay, and the muscle splitting is preferred. Now let's study about the incisions through the rectus sheath. So the incisions through the rectus sheath are commonly used and they are widely used, that means, but only if rectus muscle remains intact and nerve supply remains intact. Actually what happens that during closure, anterior wall is sutured separately, okay, and the posterior wall is sutured separately. So the rectus muscle springs back into its normal position, and what is the result of it? There will be very strong repair and there will be very little loss of the function. Okay. Now let's study about some common abdominal incisions. Now in the commonly performed abdominal incisions, the first one is the paramedian incision. So what is the definition here? A vertical incision made about 2.5 centimeter or 1 inch lateral to the midline, and it runs actually parallel to the linea alba. Okay. Vertical incision, paramedian incision is a vertical incision and it is 2.5 centimeter or 1 inch lateral. 1 inch lateral to the midline, and it is actually performed parallel to the linea alba. Okay. Now the uses here are, these are used for the supraumbilical, and the supraumbilical is usually used to expose the upper abdomen. That means examples are the stomach, liver, pancreas. If we need to expose those options, we perform the supraumbilical paramedian incision. And what happens, it also used for infraumbilical paramedian incision, that is used for the lower abdomen, and that means for the pelvis. And the examples are the organs that we use to expose, in that case, a urinary bladder, uterus, rectum. And the question is, can it be extended? Yes. For very large operations, the incision may extend along the entire length of the rectus sheath. Okay. Now what are the steps of the operation here? Let's study that. So what are the steps? Exactly we are going to discuss as it is mentioned in Snell. So the step 1 is expose anterior rectus sheath. Okay. Then step 2 is incise anterior rectus sheath 2.5 centimeter lateral to the midline. Okay. Then the step 3 is the separate the medial edge of the sheath. Okay. And the step 4, the result will be there will be a free rectus muscle when we will separate the medial edge of the rectus sheath. Okay. Then the step 5 will be the retract rectus muscle laterally. Okay, and that is actually very important to retract the rectus muscle because its nerve supply remains intact in that case. Okay. Then the next step will be we will be exposing the posterior rectus sheath. Okay, and then we will incise the posterior sheath, transversalis fascia, and peritoneum. And at the end, abdominal cavity, as a result, the abdominal cavity will be opened, and after performing all the changings or amendments we need to perform in the or on the organs, we will close the wound layer by layer. That means first we will close the posterior transverse peritoneum, then transversalis fascia, then we will close the rectus sheath. Okay. Now, what are the advantages of performing paramedian incisions? In that case, there will be strong repair. The muscle and its function will be preserved, and the nerves will be preserved most importantly, and there will be good cosmetic experience. Okay. Now let's move towards the next incision, that is pararectus incision. Now the incision is made along the lateral border of the rectus muscle. Okay. That means at the linea semilunaris. The lateral border of the rectus muscle is called the linea semilunaris. Okay. And instead of retracting laterally in the case of pararectus incision, what happens that the rectus is retracted medially. Okay. In the paramedian incision, we discussed that in that case, when the incision was made medially, the pararectus retracts laterally. But now when the incision is made laterally, the rectus muscle retracts medially. Okay. And actually this exposes the segmental nerves entering its posterior surface as a result. Now, there will be small openings. So if the exposure, or you can say if the opening we require is small, the nerves can simply be displaced upward or downward in that case, and there will be no injury, no chance of injury. And the disadvantage here is, that is very important, if the incisions need to be enlarged, or one or more segmental nerves must be divided, and the post-operative rectus weakness occurs in that case. Okay, because if there is a division, if we need to divide or cut the nerve, then in that case there will be post-operative weakness. Okay. Now the next common abdominal incisions that are usually made are the midline incision. So the next third one is midline incision, and that is actually, remember, one of the most, you can say, common, or one of the commonest abdominal incisions, the midline incision, and that is actually made through the linea alba. Okay. Now the structures cut during this are the linea alba, transversalis fascia, the extraperitoneal connective tissue with a little amount of fat, and the peritoneum. And it is actually easier above the point of umbilicus because linea alba is wider there. And if you have remembered, or if you have taken the previous lectures in my abdominal playlist, then you will know that, then you are exactly pro with this concept, that why the linea alba is wider above the umbilical point and why the linea alba is narrower below the level of umbilical point, because we have discussed it already. Okay. Okay, that's why it is easier above umbilicus, because the linea alba is wider there. Now let's study about the advantages. So the advantages of this incision will be, that is the midline incision, that there will be rapid entry, there will be no muscle damaged, there will be no nerves damaged, there will be no blood vessels damaged, and it actually can easily be extended, and it can even become a T-shaped incision for greater exposure. In T-shaped incision, we are then performed above that, we are also performed laterally. Okay, we are performing laterally. Now there is an additional point here, and that is the anterior and the posterior rectus sheath are cut transversely. Okay, the rectus muscles are retracted laterally in that case, again in case of medial incision. Okay, now the next fourth common incision is the transrectus incision. Okay, now this technique is almost same as the paramedian, the first one we discussed, but the basic difference here is that instead of retracting rectus, the rectus muscle itself is cut longitudinally here. As you can see, the rectus muscle is cut longitudinally and it is exposed here. Now the major disadvantage of this process is that the nerve supply to the medial part of the rectus is actually divided, and that leads to the weakness, and therefore it is rarely preferred in today's practice. Okay, now the fifth incision is the transverse incision. Okay, so the transverse incision is actually made horizontally, or it can be above the level of umbilical point, or it can also be below the level of umbilical point, and it may be small, or it can extend from flank to flank. Okay, it can be performed small and it can extend from flank to flank. and the route here is actually, it may pass through the rectus sheath, the rectus muscle, the oblique muscles, and the transverse muscle, because immediately we are going to have the rectus muscle, but laterally we have all our oblique muscles and the transverse muscles. So there is a cone here, you can say. Then the advantages here are the it usually damage only one segmental nerves. Okay, it usually damages only one segmental nerves, and therefore there is very little post-operative weakness, and it provides excellent exposure, and it is well tolerated. Okay, and about the closure of this incision, so the closure is done in layers. That means there is no need to suture the cut ends of the rectus muscle, and provided the rectus sheath is repaired carefully. Okay. Now the sixth technique here is about the muscle splitting, or you can say the McBurney's incision. Okay, the muscle splitting or the McBurney's incision. Now this is one of the most important clinical incisions here, and it is used mainly for appendectomy or cecostomy. Okay, appendectomy is for the appendix, and the cecostomy is actually for the cecum. Now about the limitations. So the limitations or the cons here are, it provides limited exposure, and if the diagnosis is uncertain, use the right infraumbilical paramedian incision instead. Okay, paramedian incision, we are going to use the paramedian, the first one, if the diagnosis is not confirmed. That means if you are not sure that there is a case of appendicitis, then it is better to perform the paramedian incision, and specifically the infraumbilical right paramedian incision. Okay, now the site here is an oblique incision in the right iliac fossa. Oblique incision in the right iliac fossa, about 5 cm, or you can say 2 inches above and medial to the anterior superior iliac spine. 5 inches or 2 cm above, to 5 cm or 2 inches above. And actually this corresponds approximately to the junction of the lateral 1/3 and the medial 2/3 of the line joining the umbilicus to the anterior superior iliac spine. That means near the McBurney's point, and we have already studied the McBurney's point in our previous lecture, but I'm mentioning it again, the point where if we draw a line from the point of umbilicus to the anterior superior iliac spine, then a point from the lateral 1/3 and medial 2/3 of this line point is called the McBurney's point, so it is actually performed there. Okay. Now the muscles here are the external oblique, then eventually internal oblique, then transversus abdominis, and these are actually split along their fibers, and they are actually not cut across them. We split them along their fibers. We are not going to cut them across their fibers, and then eventually they are retracted as a result. And then the transversalis fascia, about the transversalis fascia, and then eventually the peritoneum, they are incised finally. And the closure is again layer by layer, like we perform the incision layer by layer, so the closure is again going to be performed layer by layer. And the major advantage here is there is actually no post-operative, you can say, muscle weakness in that case, because the cutting or splitting of the muscles or layers is provided along the direction of their fibers, and there is no post-operative muscle weakness, and because the muscles are split rather than transected. This is actually a point. First point is we are actually performing along the direction of their fibers, and the second point, we are actually not cutting the five muscles, we are actually splitting them. Okay. Now about the third and seventh incision, and the seventh incision is about the abdominothoracic incision. So abdominothoracic incision is used when both the thorax and the upper abdomen needs to be exposed. And the example here can be the lower end of esophagus during the esophagastric resection for carcinoma. That means if there is a carcinoma of the esophagus, then both thorax and the abdomen needs to be opened. Then the technique here is actually an upper oblique or paramedian abdominal incision is extended upward. It is extended upward and laterally into the 7th, 8th or 9th intercostal nerves, or into the 7th, 8th or 9th intercostal space. And in that case, that is the costal arch here. So the costal arch is transected and the diaphragm is because the diaphragm is also present at this level, so the diaphragm is also incised, and a rib subsiding retractor provides wide exposure of the upper abdomen and thorax, because we actually use a retractor here for the ribs that separates the ribs or retract the ribs, so that leads to a wider exposure. Okay, now about the closure. So the closure is at the end of the operation. What happens? The diaphragm is repaired with non-absorbable sutures. Okay, non-absorbable sutures, that are kind of sutures we performed, and then the costal margin is reconstructed, because that is the duty of the surgeon to again reconstruct, because we have cut the or transect the costal margin, and the abdominal and thoracic wounds are closed finally. Okay, so that was about the closure of the abdominal thoracic incision. So that was totally 7 common incisional techniques that are usually used in our common practice. Now let's revise it, and some about this is a quick comparison table. I will suggest you to take a screenshot of this. Okay, or if you will if you want it, I can also provide these notes to you if you ask me in the comment box, because this is a very I have generated this table, and this is a quick comparison table of all the 7 techniques. About this is discussing their direction, the muscles that are cut or split, the nerve damage if that is happening or not, the post-operative weakness if that is happening or not, and the exposure, that what kind of exposure we are getting in each kind of technique. So that is actually very important, because this topic is not very important at our level, and that means for first year and second year, but sure, if you are pursuing in surgery, that means that is very important, but it is not that much important from, you can say, the viva point of view. Okay, so that's why this is I have generated this quick revision table to revise all the 7 abdominal techniques. Now let's discuss summarize it, or let's discuss some high yield viva questions here. So some high yield viva questions. The first question is why are the abdominal incisions made parallel to the muscle fiber? But first I will suggest you to answer these questions, to stop the video here, to answer these questions first in your mind, to know that how much of you had retained from the lecture, and then listen to my answer. But first, that the answer is, now again come to the topic, the answer is the abdominal incisions are made parallel to the muscle fibers to minimize the muscle damage, to preserve the function, to reduce the post-operative pain, and to allow the muscle fibers to fall back into the position during closure. Now, the second question can be, what is the safest abdominal incision that the examiner can ask you? So the midline incision is the safest abdominal incision, because it avoids the muscles, the nerves, and the major blood vessels, and it is actually performed at the level of linea alba. Now, the third question is, which incision is used for appendectomy? Remember, the McBurney's or muscle splitting incision is used for appendectomy. Okay. Now, the fourth question is, which incision provides the strongest repair? So the answer is the paramedian incision, the first incision, because the rectus muscle and its nerve supply are preserved in that case, and the rectus sheath is repaired separately. Okay. Now, the last question is what happens if segmental nerves are cut? What are the cons here? So it leads to the paralysis of the corresponding abdominal vessels, and that leads to the weaknesses of the abdominal wall, and also it can also lead to the forward bulging of the abdominal contents. That means visceroptosis, and in severe cases we are going to need a surgical belt. So that was all about our today's topic of abdominal incisions. Hope you liked the lecture. Do comment, like, and share it with your other peers. Thank you so much. Allah Hafiz.